All right, good morning, everybody. It sounds like we're having quite a few people sign in at the moment. I'll go ahead and get my screen sharing and we'll go ahead and get started. So this is our November Utah Children's Care Coordination meeting. If you're joining us for the first time, welcome. And on today's agenda, just an overview, we'll start with some announcements and updates. We have a case share and brainstorming, and then our meeting topic today centers around trauma screening. So that'll be the bulk of our meeting with our evaluation and wrap up at the end and ending by 10 o'clock. So if you're joining us for the first time or you're joining us for many times and just we'd like to know who you are. So the best way for us to do that in this setting is if you'll take a moment to rename your profile. You can look on your picture and click on the little dots up in the upper right-hand corner. You'll see an option to rename. As you can see, I'm doing mine now. And that will give us a chance to kind of get to know each other in this virtual format and identify who each other is. Also, we would love if you're able to join us on camera to see your face. I know that's not always the most comfortable for these virtual meetings, but it does help us get to identify each other, as especially in our brainstorming and case share sections. That would be really great. For announcements, as always, we like to encourage you to recruit anyone that you may be working with into the Spark study, any new diagnoses of autism. It's a great way for families to get a lot of really great free information and resources related to a new diagnosis of autism, and it helps better understand the genetic link for autism. So we encourage you to enroll anyone in that you are able to. And then I have an announcement today about a new journal that the University of Utah Department of Pediatrics is working on called Topical Reviews in Pediatrics. And I'll navigate out to the site here in just a minute, but the idea is that it will be it's reads like an online medical journal, and it will have quarterly issues. The first issue is due out this November, and some sample articles so this month they are going to have something around learning about cystic fibrosis, an FAQ for families, and then infant formula ingredients and components. And this one has a lot of insights into the implications of different formula components. So might be kind of an interesting read. It also has the link to the medical home portal archive site on it as well. So it's using some of the previous structure of the medical home portal editorial board and authors group to continue to publish information that's pertinent to families around topics for the health, well-being, and success of children and adolescents. So here's their website. As you can see, the issue, it says November 2024, but if you click on it, nothing's up yet. The people that are working on it said that it should be available in the next day or two, but it'll have articles, clinical tools, patient education, and some creative works. And there's information here about submissions, and the editorial board and policy. And then it does have, like I said, a link to the medical home portal archive site on it as well. It gives a little bit of an overview of what that project was, as well as the links to the content that was previously there. So, we were really sad to not be able to keep the medical home portal project going, but this hopefully will be able to continue to publish really high quality information around children and youth, especially with special healthcare needs. So any questions on that? They do have a mailing list. If you're interested in joining the mailing list, you can pop your name in the chat and comments. I'm also going to push their month or their quarterly issue emails out to the whole listserv as well. So you'll also be getting information that way. But if you want a more direct link to them, you're welcome to join their listserv also. All right. For another announcement, I just wanted to give you a little preview of our 2025 UCCCN topics. We met as a planning committee and kind of came up with a list of topics based on input from your evaluations, and then also the kind of some just issues we haven't touched on in a while and wanted to revisit. So here's just an overview of kind of what our calendar looks like for the upcoming 2025 year. And we do obviously have some spots there, especially November. So if you have another idea of something you want to cover, again, you can pop it in the chat or put it in your evaluation at the end of this meeting. But we're excited for this lineup of topics. We think it'll be really another great year of learning. Along those lines, with the planning committee, we talked about a few things about some ideas for changing this meeting up a little bit, and would love your input on that as well. So one thing we talked about is the length of the meeting and whether or not a 60-minute format might fit a little better versus a 90-minute format. And then we talked also about moving case shares primarily to like the listserv or the Facebook group as a place to interact, because it seems like those interactions kind of happen naturally in that setting more frequently than in this setting. So would love your input on that. I have a little poll. If you'll take a second to just fill it out, that will help us kind of get a good idea of whether or not we'll shake up the meeting format for the 2025 UCCCN meeting series, and I'll announce if we're going to make any major changes to that at our next meeting. But go ahead and answer, fill in this poll and just take a couple minutes. Just 2 questions, real easy. So it looks like just at the moment, we have almost everybody who's answered. The consensus is that a 60-minute format would work a little better for most people. And then it's a split on them in favor of moving the case presentations to the listserv. So, with a lot of maybes. So any discussion on that? I'd love to hear your comments on that. How you think that would impact this group. Here's the results.
I think just personally, I feel like there's a lot more collaboration when you're talking about a subject and talking through it rather than typing it out. Sometimes just putting the words together can be a little difficult, and talking is a little bit more collaborative, and just hearing other people's voices and the multiple people from different offices that can help you. I think that's where community is built a little more, and just putting a name to a face, hearing their voice, it's a little more comforting, just for me personally.
Yeah, that's great. Thank you, Haley, for sharing. Anyone else?
Maybe, sorry, this is Amy. Maybe those conversations can happen in both places, and maybe those bigger conversations, to Haley's point, or if things rise up that need to go or come to the group for more of a chat, would be good. So in both.
Yeah, I think that makes a lot of sense. I think there's also still time in the agenda to do the case shares, and maybe we move more announcements more toward the listserv to kind of free up some of that time at the beginning of the meeting. We've also, in the last several meetings, have actually booked multiple presenters. And so, if we focus on just like a single presenter for each meeting, I think we can keep in that 60-minute format pretty well, in addition to having some case share time. So anyone else want to share?
I would. I oversee, can I share my screen by chance?
Yeah.
I oversee case management certification, and we recently made some changes. It used to be children and adult case management, and now there is just one behavioral health case management certification. And then we have homeless services case management, which is for targeted Medicaid reimbursement case management. So we updated our entire site. We updated the certification training. So supervisors will no longer have to correct a actual test and exam. Once you go through the exam, it'll give you a score, and then you just need a signature page. And then one thing I'm really excited about, and I would love to have more participation from broad people in the community, is our monthly case management training. It's on the third Tuesday of the month from 11 to 11:50, but starting in January, it'll go until 12:30. And in December, the Utah Crisis Services, so mental health crisis services present, and then civil commitment in January, and in February, Safe at Home. And that either will be a presentation or a training specifically to get certified in that. And if you're interested in kind of like what these meetings are, what kind of information, I have all our past recordings right here. And I'm trying to get in contact with people from different offices across the state that offer free services to ensure that our case managers are trained on the diverse array of services available. But I would like to open this up to anybody and everybody that is interested in the training topics. So you can check out this website. The training topics will be in our calendar, and then the recordings will be available as well.
Haley, I have a question. Is there a link that you can like sign up to just always have an invite on your calendar, or do you need to sign up for each individual one that you're interested in?
You can just, so because there's so many case managers and there's so much turnover of where they're going, you can just, if you go on that calendar, you can add that to your calendar.
But you have to do it for each individual one, correct?
Yes.
Okay, thank you.
Yeah.
Great, thanks, Haley. Any other comments on the 2025 Utah Children's Care Coordination Network learning session topics and or ideas about changing the format? Sorry, I lost my screen. There we go. There we go. Gets hidden behind windows and then I can't see faces. Okay. So we do have a case share today from Tony Estrada as part of the Integrated Services program. So I'm going to go ahead and turn a little bit of time over to her.
Thanks, Athena. Good morning, everybody. Just wanted to share a case that I received about a couple of weeks ago. And so it's still fairly new. This case that I got, it was a referral from DCFS. And it's a 60-year-old dad who currently has stage 4 cancer. He is raising 4 boys. The oldest is a little, or is in his early 20s, and he has high-functioning autism and is working. And then he has a 15-year-old that is in high school that's typically developing. And then the 2 younger ones are 14 and 12, who have severe autism, nonverbal, still in diapers, need a lot of care. They're both in school and attending school. The mom passed away unexpectedly in June from a heart attack. Dad is currently on disability from work. So he is receiving a little bit of money, and then the 2 younger children are receiving Social Security disability. They have Medicaid. We found they were not, so dad wasn't really involved in a lot of the care and getting them signed up for programs and services and things like that. So since mom passed away, he's had to look into that, and just didn't know where to even turn. So he wasn't even sure if they were on the DSPD wait list. I contacted my contact at DSPD, and they were not on the list. And so it's been hard to get the dad. We have scheduled a couple of appointments, but one time the kids were sick, another time he wasn't feeling well. He's still undergoing treatments. And so I was able to talk to somebody at DSPD, and they said as long as we turn in the form, it's like 1-1 for DSPD, then they'll at least get assigned a caseworker, and the caseworker will then get a hold of dad and get the process going. So we did that. I was able to get them sent off yesterday, and the caseworker is already, I think, emailed me back. So that's great there. I try to talk about, like, assistance for, because they are renting a home. Their rent is $2,000 a month, but he's not too worried right now with finances. I think he's just kind of, scraping by, and not his main concern right now is obviously the boys and what's going to happen to them. So he didn't really want to do anything with any other services like utility assistance or obviously ABA therapy. I was able to talk to his sister. So he is 60 and he's the youngest of his siblings. So they don't have any family members that can take the kids if something, well, he said when something happens to him. And so he does have a sister that he gave me her phone number. I was able to get a hold of her finally on Monday, and she feels like one of the boys can probably learn to speak and my progress with ABA therapy, but the home life is just survival. So in a way, that's kind of where we're at right now. And if anybody has any input or any suggestions, I would greatly appreciate it. It's a hard case.
That sounds like an incredibly complicated case, Tony.
Yeah.
So what is it they're primarily looking for at this point in time?
So, like, where the boys, what's going to happen with them once he passes away? Because he said it's not a matter of when it's, or not matter of if it's when. And there's no family members are able to take them once he does pass away. So he just wants to make sure they're going to be taken care of, and there's going to be a place for them to go. So hopefully that caseworker will get in touch with him soon, and they'll get things figured out. I just don't know with DSPD. I know there's no funding right now. So wait and see. I think eventually, if he does pass away, the state will just take them in a way. So
no other relatives beyond the sister, no cousins, no long distance.
it doesn't sound like there's anybody that's willing to take them on. So his sister told me that they're really hard because they need a lot of care.
Tony, is he worried too about just, that when he goes that they'll just be left to the system? Is he like he'd feel better if he knew who those people were before he passes, or
Um, I mean, I think so. He did say something about, wanting to tell whoever takes them, like, about their needs and wants and likes and dislikes and things like that. So I'm going to print him out like a care notebook type thing for them, and hopefully he can work on that a little by little.
With their school or their community or church or anything, have they identified like somebody who will check in with the boys now and then?
Good question. I'm not sure. They are attending school. They're in and they're in special ed, but I didn't ask about,
Mhm.
I know he just sends them on the bus and then they come home. So
Yeah, because if the boys have like a favorite person that understands sort of how they communicate, or that might give some peace of mind to know that there's somebody who, kind of knows them, that while they
mhm.
can't take them into their home, maybe they could check
At
in.
least have this. Yeah, that's a good idea. Thank you. And thank you, Carrie.
And maybe like Jade was saying, I don't know, can like there be a person that he knows that can be the guardian ad litem? Like they're not agreeing to take the kids on, but that they would be legally allowed to be involved in the decision making. I don't know if that's a
Mhm.
thing. Like, could that be a thing?
That's a good idea too.
And Natalie just made me think of big brothers, big sisters. I don't know if maybe there's even somebody there interested in hanging out with that would maybe open some additional doors to connection with individuals.
Okay.
And I don't know, Tony, this is like, I'm just making this up off my hip bone, but like there are families, that work with like Chrysalis or some of those that do like long-term respite care who really are interested in adopting kiddos that have problems. And maybe that's something that could be looked into. Like you said, there's no DSPD money, but like maybe if something comes available that dad could get some respite and families. I mean, I'm working with a family now who has a very difficult kiddo, and the temporary guardians aren't certain that they're going to take custody. And so they're kind of working back and forth with respite, and they've actually identified a family that would be willing to. So I don't know, Tony, this is, and did you say DCFS is involved already or they're not?
Yeah, that's who
Yeah, okay.
referred them to me. And so I'm wondering if they would know of somebody, or the DSPD worker, once she gets a hold of them, maybe she would know of somebody that would be interested. Thank you.
One thing I'll say with the DSPD intake, I've had a few people who've filled out the 1-1, but then the DSPD caseworker wasn't able to reach them, and so it just closed. And so then, I'll call and I'll say, hey, where are they in that process? And they're like, oh, it closed. We couldn't reach them. So
Oh,
sometimes some follow-up, and maybe if if they're aware ahead of time of the situation where there may not be someone to follow up, within the family on that
uh-huh.
paperwork, maybe they'll have more bandwidth to really pursue getting that completed.
Okay, thank you.
Yeah.
And Tony, I apologize. Someone walked into the office as you were giving some of the particulars on the case, but how old are the boys again?
12 and 14.
Okay.
And did you say they both have autism diagnoses?
Yes.
Tony, would the older child be able to participate in any like transition to adult healthcare services, like just talking about what his goals are? Like, does he have that any kind of that ability to participate at all? Okay, thanks.
They're both nonverbal. They're both in diapers.
And the 20-year-old, is he connected in with a, like, I don't know, the Uni Home program or the autism program can be really supportive. I used to work with some adults with autism who lost both parents. And then they're just like, I don't even know what to do. I don't know how to pay a bill. I don't know how to, you know,
Mhm. Are they
how to,
connected with, what did you say, what program?
um, the University of Utah Autism Adult Clinic and Uni Home
Is it
program
neurobehavioral home? Is
or
that the one?
neurobehavioral. Yeah,
Okay,
yeah. That's the one. Sorry.
Tony, when they're participating in the home program, that becomes basically the ACO or HMO on their
Yeah.
medical card. And the beauty of the home program is they do primary care, psychiatry, uh, psychology, all sorts of meds management. It's kind of one-stop shopping for kind of neurodivergent folk up there at the at uni at the
Just
home
wondering
program.
how he would get to his appointments. So, okay, but I will look into that. That's a great idea.
Thanks, everyone. That's a lot of really good resources on a really difficult case. Does anyone else have another case they want to bring up, or resources, updates, announcements you want to share? This is your time.
This is Dora from Shriners Children's. I am one of the liaisons for Shriners Salt Lake. I was just going to let you know that Shriners Children's is doing a national community assessment. So if I will go ahead and send that a little later today, if it takes about 3 minutes, this is just how they see what is lacking in the community, and that's how they've known to open new resources and across the system. So there's 22 locations in the United States. But if that's something that you would be able to do, we would love to hear back from you. So thank you.
Thanks, Laura.
Dora, on a second note, this is Natalie Allen. I need to talk to you. Can you send me your email or some way that I can contact you? I'm sure if I dig deep enough, I can figure it out, but I have a referral for you and I need some help.
Absolutely. Yeah,
Thank
you can
you.
call me.
Okay.
I'll send it, I'll put it on the chat.
Then I was just going to bring something up. I went to a really good training yesterday just on trauma and trauma-informed care. And I just wanted to throw that out as a possible topic for something that we could explore with this group. The training was a half day, and so I cannot imagine condensing that into 1 hour or less. But I did wonder if that would be a topic of interest for this group. So I just wanted to throw that out there. I do think that possibly this group, because they do this training regularly, it's really what their function is, that they might be able to give us some key takeaways that would be, possibly valuable for looking at trauma with the families that we're working with, and keeping that in mind as we are dealing with some, tough situations. We look at motivational interviewing all of the time, but sometimes keeping a trauma-informed lens with some of that can be a helpful way to approach our families who are dealing with a lot of issues. So I did want to kind of throw that out as a possibility.
Is anyone else?
So we do still have that November spot open later in the year, or we could something we could look at next year. 2026 as a topic, if not next year.
Perfect. All right. We'll move into our learning session portion of the meeting. Today is all about trauma screening, so this might be, it might fit well. Eric, you can see if this covers kind of what you're thinking as well. So today we have Shannon Chaplo joining us, and she's a pediatric clinical psychologist who works primarily at the Center for Safe and Healthy Families. And I am going to go ahead and turn the time over to her.
There we go. Thanks, Athena. And thanks for the invitation to come and meet with your group. Being just like a little bit of a fly on the wall. It's been already like kind of interesting to hear the families that you all are working with. So first I'm going to apologize. I'm getting over a cold. So if I say something that doesn't make sense, please just kind of pause and interrupt me and ask me to repeat something because I'm a little nasally. But as Athena mentioned, I'm a clinical psychologist and I'm in the Department of Pediatrics at the U here. I've got a long history with the U. I did my training at the clinical psychology program. And then I was telling Athena over email, I went to North Carolina for a good 7, almost 8 years to finish up my training, was at Duke and UNC for a little while. And then I came back to the U to join this department back in like July 2023. So it's been really nice to come back to Salt Lake City. Most of my background and my training has been in basically supporting child serving systems to do trauma-informed care practices. So Eric, you launched off what I'm going to talk about really well. Trauma screening is just kind of one element of that. And then I'm still a very active clinician. So I'm literally at Safe and Healthy Families. We're in the outpatient building of Primary Children's. And we also have locations at the new Lehigh Children's Hospital. And then we've also got a satellite location too in Riverton. And then I don't know, just by like a raise of hands, are people familiar with Safe and Healthy Families and kind of what we do? I'm going to say there's probably like a mix. So we're really specialized in providing outpatient treatment to kids and families who have been through trauma and other adversities. So I'm part of the therapy team here. And then just to kind of put a plug to, we actually do a lot of trauma-informed care training. So if that's something that you all are interested in, of getting a little bit more broader than just what I'm going to talk about today, yeah, please reach out. So that's a little bit about me. And then I told Athena that I'm pretty good at sharing my slides. So we will test out that and see if it goes okay. And then as I'm going through too, I know like slides can discourage conversation, but if you have like a question or a thought, please put it in the chat or interrupt me. I don't mind being interrupted at all. Let's see. Can people see that okay? Awesome. And then Athena, I might rely on you too, because I've only got one screen. So if people do put something in the chat, yeah, please bring it to my attention. Yeah. So I'm Shannon, and then I would be amiss to not mention the rest of my team. So I work alongside Brooks Keeshan. He's a child psychiatrist here. Lindsay Shepard-Adulahad, she's a social worker. And then Portia Vaughn, she helps us with a lot of our data collection. She's a medical librarian by training. And so I'm going to talk a little bit about kind of trauma screening broadly. And we've been doing this work since 2016. So I'm going to talk a little bit about how we've been doing it more in primary care within our own healthcare system. And part of this funding actually comes from the National Child Traumatic Stress Network. So if you're not familiar, they've got a ton of resources, and they've been funded by Congress since like 2000 to basically build up kind of the amount of like trauma-informed and evidence-based treatments that we have for kids across the U.S. And so Safe and Healthy Families was actually originally funded in 2000. They were one of the original sites. And then we were refunded in 2016, and then again in 2021 to do this work. So we've been really fortunate to have 2 rounds of funding to do this. And it's really all about being able to kind of build up the way that we can identify trauma in our state, but also respond to it. And then we've been doing this nationally too. So I'll talk a little bit about that later. just some learning objectives to kind of keep in mind as we're going along. Again, we're just going to skim the surface about what kind of child trauma screening is and why it's important. Kind of also more important too, because I'm one of those people where if like we're going to ask about trauma, I want you to do something with it. So also kind of how you're going to respond. So I'm going to go through the model that we developed back in 2016 and that we've been utilizing since, called the care process model for pediatric traumatic stress. So you'll probably hear me call it the CPM, but that's kind of the one I'm going to zero on in today. And then I'm hoping to, kind of seems like you all are a collaborative group of kind of thinking about how any of the ideas and concepts that I share might apply to the work that you all are doing. So I thought I would start really, really broad just to make sure that we're all on the same page of just what is like child traumatic stress. I think many of you have probably heard of ACEs, and this is a little bit different where we're kind of talking not only about what has happened to kids, but also kind of what the impact has been. So here on the slide, I've got kind of a bulleted list of what PTSD can look like in kids. And so that can look like it having intrusive thoughts or memories. So it's kind of having like memories about what happened pop into their mind when they don't want them to, strong feelings of anxiety or stress. Sometimes that can also look like wanting to like avoid talking about, thinking about, having feelings about the experience that they've been through. Another hallmark symptom of PTSD in kids is kind of like it really kind of alters the way that you think about yourself and your relationships in the world. So kind of thinking about how it can change kind of how you view yourself as a good person or not a good person, whether or not you feel like you can trust other people. For a lot of the kids that get involved in the legal system to kind of that like sense of justice and whether or not things are fair. A lot of times too, we see things that overlap with just kind of feeling sad and lonely, withdrawing from others that can look a little like depression. And then a lot of our kids after a traumatic event have sleep problems. So that can look anything from having difficulties falling asleep, staying asleep, and then we're on the extreme side too, like ongoing nightmares or night terrors about what happened. So I'm not going to talk a lot about ACEs today because part of what I want to do too is kind of what we respond. So it's not enough to just kind of know like what a kid has been through, but kind of how they've been impacted. And part of that too is just that trauma and the way it impacts kids and families is so individualized. I might have one kid that has had the same exact experience. Maybe they've been sexually abused, and I have another kid who's been sexually abused under similar circumstances, but the way that it's impacted them and how those trauma symptoms manifest could be very, very different. So moving on, the other reason why we kind of need to think about trauma screening as a key trauma-informed care practice is that unfortunately there's just a high prevalence of trauma exposure. There's so many different statistics out there, but the CDC most recently, even if you're just kind of looking at specific types of trauma, like for example, sexual abuse, like 1 in 4 girls will be sexually abused by the time that they're like 18, and it's about like 1 in 6 for boys. Even in some of the systems that I've worked with here, I used to do a lot of work in juvenile justice here in Utah, and kids coming to detention centers here in Utah, 90% of them that we talked to had experienced at least like one traumatic event, and a lot of those kids had experienced multiple. And on average, I think it was like 4 or 5. One thing that we do know from the ACEs study too is that trauma is connected to poor health and mental health outcomes, not only like during childhood, but without treatment, those impacts can last into adulthood. So things like depression, anxiety, but also kind of the things that I think a lot of the families that I work with care about of like, is my kid gonna, graduate from high school, or are they gonna kind of go on and live a healthy life that I want to see them do? Another reason, and this is what I'm going to talk a little bit more in depth about today, is that the trauma symptoms often go undiagnosed or misdiagnosed. So if we don't ask about them, especially in a primary care setting, a really well-meaning pediatrician, if you've got a kid and family that are saying, yeah, my kid's been really on edge lately, they're having a hard time paying attention and focusing, and they didn't know that this big thing had just happened, their minds might go to like, oh, this kid has ADHD or something like that. Or even if you're just kind of remembering the bulleted list that I had to, a lot of times it can just look like plain old depression or anxiety. But if we don't know if something happened, then we might kind of go down a different care pathway that might not actually be helpful. The other reason why, and this has been really important for me in my career, is that we also have a ton of evidence-based treatments that we know work for kids and families that are dealing with traumatic stress. But if we don't identify them, then they're not going to get those services. And I think I've been doing trauma focused treatment probably since like 2012 now. And I think I can probably count on my hand the number of times that kids and families, they just kind of come immediately to see me. Usually they've interacted with some other healthcare setting or CPS before they're kind of getting a referral to Safe and Healthy Families. So it's really important too that we're doing this work in other systems. Fortunately too, now there are several organizations too that like the American Academy of Pediatrics that are actually like recommending that we do trauma screening too. So now we've got some policy support behind these things too. Kind of like doing a little bit of a deeper dive too of just kind of like, oh yeah, that misdiagnosis piece and the overlap. So I put together this table, and on the left-hand side, I've got trauma-related difficulties. So those are some of the symptoms that I've already mentioned. And then on the right-hand side is just kind of how it can overlap with a lot of other presenting concerns, both behaviorally and emotionally. So for a kid that is having trauma-related anxiety or depressive symptoms, they might get misdiagnosed with other mood disorders, a major depressive disorder. I've even had some little itty-bitty 5-year-olds get diagnosed with bipolar when that was not appropriate. Kind of thinking about self-regulatory impairment, those are the kids too, where they get misdiagnosed with something like ADHD or ODD, so substance use disorder, personality disorders if they're older teenagers. Dissociation, I didn't talk about that on that initial slide, but for a lot of kids, this happens either during the trauma, but then it can also be kind of like a safety mechanism after. And for a lot of kids, if they're actively dissociating to a trauma reminder, it almost looks like they're kind of spacing out. So for a lot of caregivers and providers, again, those might get kind of misdiagnosed as like this kid is having a psychotic episode, or they might be having ADHD. A lot of our kids also have impulsive and aggressive behaviors, especially our little kids, right? They're not always able to say and express that I'm having a big feeling. So it kind of comes out of like, I'm hitting my little brother or I'm hitting other kids at school. And that runs the risk too of getting diagnosed with something like oppositional defiance disorder. And then the last two are more about like eating problems. That's pretty common. And then attachment difficulties. So you might have a little kid that they've been through something hard and now they're having a really hard time separating from that caregiver. Maybe you had a kid that was really good at going to school and now they just, they don't want to go and they're avoiding. So that's part of why our work is really important. And then this one too is just even a deeper into the overlap of trauma and ADHD. A lot of the kids and families that we work with at Safe and Healthy Families will come in where they've had a diagnosis of ADHD, but their trauma history and their trauma symptoms have never been addressed. So it's hard to know too of like, well, maybe there is true ADHD, but it's actually making those symptoms a lot worse, or it's been trauma symptoms that have been mistaken for ADHD symptoms. And if this is something that you're interested in, I've got a really great, there's a really great NCTSN resource too that kind of has like a deeper dive into the overlap of traumatic stress and ADHD. So moving on to the other reason why it's so important is that I went to a conference earlier this year and a guy said it better than me of like, there's no ACEs pill. So there's not actually like a medication that's effective at treating post-traumatic stress symptoms in kids. And of course, I'm biased, right? I'm a clinical psychologist. So I believe in therapy and I see kids get better. But even from the psychiatry world, they put this out back in 2010 of that it's not actually medication that should be the first line treatment for treating kids with PTSD. It's actually trauma-focused psychotherapies. And this comes from like a long line of randomized control trials and research. And so if you're a person where you see a bunch of data and start to zone out, you have my permission to zone out for a minute. But basically what this really busy slide is saying is that treatments for PTSD, it's psychotherapy, and that those are actually more effective than waitlist controls and active controls. And so what you're seeing on the screen are what we call like forest and tree plots. And basically what they did is kind of like a fancy technique called a meta-analysis, where again, we don't want to look at like one individual study that said like, oh yeah, PTSD treatment is, better than a different type of treatment. And so what a meta-analysis does is that you're actually able to take multiple studies that have kind of looked at something similar and get like an average effect size. And so I don't know if you can see that little cursor on my screen, but that's kind of what that's looking at. And I will say for like psychotherapy studies, that's actually a really big effect size. So what they did is that if you kind of sum all of these studies up, what you see is that, basically kind of doing a trauma-focused evidence-based treatment, something like trauma-focused cognitive behavioral therapy, is much better than just kind of a family sitting on a wait list. And I would say that's kind of like a duh moment for me, right? Like, I would hope most families are getting better if they're actively doing something like TOCBT than sitting on a wait list. So that's where the thing on the right-hand side, that chart is actually more important because that was actually comparing things like trauma-focused cognitive behavioral therapy to an active control, meaning like treatment as usual. So they're still kind of getting like the therapeutic benefit of meeting with somebody, and you still find that things are TFCBT and others are much better than other treatments that we have out there. Okay, so now you can zone back in if you're not a data person. So I will say too, again, easier said than done because there's also just a lot of different challenges in identifying traumatic stress. And this kind of comes from not only the work that we're doing in primary care and children's advocacy centers, but other systems that we've worked with. The kind of thing about primary care too, and even the work that you guys do, right? Like families might just not volunteer on their trauma history unless they're asked directly about it, right? It's not something that like we like to talk about as a society. A lot of times when I tell people what I do, they're like, oh, I don't know how you work with kids that have been sexually abused. Like I could never do that, right? It's just something that we don't like to talk about. The other thing too is that even coming into primary care, most families and kids aren't coming to primary care to tell their pediatrician, like, yeah, my kid has PTSD. This is what I want to focus on, right? It's usually something about like my kid is maybe having a lot of anxiety or they're not sleeping at night. They're not doing well at school anymore, right? Those might be the things that they're coming into primary care for. And then sometimes too, and not because families don't necessarily kind of want to do this, but right, and even providers don't do this sometimes, right? They might not be connecting that like, oh yeah, my kid just went through this really big thing. Grandpa died from a heart attack at our home and the ambulance came out. It was really scary. And now my kid's been really clingy, right? Like some parents might not always make that connection unless they're asked about it. And then on top of it too, and even in our clinic, when it's most kids know that they're coming to talk about something kind of scary that happened. A lot of kids, if they're feeling kind of psychologically safe, like they might actually appear really calm. I know I've had plenty of kids and families come where the kid is having really, really their behavior problems to the point that they've been kicked out of school. But when they come to my clinic, they look like little angels, right? So there's a lot of reasons why too of just as providers, this might be challenging and families might not be making the connection. So kind of carrying the point home before I kind of talk about our model, these are just, again, some solid reasons of why we want to screen for traumatic stress. One is just improving the early identification of children suffering from traumatic stress. So we know that we've got effective treatments. And for me, I would much rather see a kid where that event has happened in the past year than it's like, oh, it's something that happened years and years ago. And all of those effects are kind of accumulating over time. The other reason why, too, is that we really want to build on family strengths. And if you can give caregivers the psychoeducation about why their kids are behaving the way that they are, it's going to also build a lot of empathy for that child that's having behavior problems from that caregiver and other professionals that are working with that kid, and then being able to connect them to kind of the right services that they need. So not all kids that have been through something are going to necessarily need to come and see me for TFCBT, but there are a lot of supports out there that can help. On the right-hand side of the screen, I've got kind of a list of evidence-based trauma screeners that are available, and I kind of honed in on things that I thought would be more relevant to you all and that have evidence for being used kind of in a brief manner and more in healthcare settings. There's the child trauma screen, the UCLA brief, the care process model for pediatric traumatic stress, which I'm going to talk a little bit more about today, the child and adolescent trauma screener, and then there's also a really cool tool from the University of Minnesota that's on the bottom. So those would be some ones to connect back to. But I'm going to talk about the one that we developed here in Utah and have been using since 2016. And a lot of this actually came from, again, of like, for a group of us here at Safe and Healthy Families of like, oh yeah, a lot of times when kids are coming and getting referred to our system, the thing that they've been through has occurred maybe years ago or even months ago. And we want to make sure that we're working with other systems to ensure that kids can get care more quickly. And so we developed this care process model so that it's not just even asking about what a kid or a family has been through, but also how they've been experienced by it. So I'm going to skim the surface, but if you do like to read and get really interested in this, I've got a QR code and then also our website, and I can plop it in the chat later too after the presentation. It's a 30-page document, and it goes really in depth of how to actually do this model, both in primary care, but also children's advocacy centers. And again, kind of I think I've kind of drilled this point by now, but basically the point of it is that if we're going to kind of screen a population, so if we're kind of thinking of a primary care practice, the whole point of screening really is that like we want to kind of identify the kids that might need more support. And not all kids are going to need something. Some kids might need just kind of like general mental health services. Some kids might need to come to more specialty care like we have at Safe and Healthy Families. But this is one way too, and especially if you're in an area of Utah where there's not a lot of mental health resources, it can also kind of help you figure out like, okay, well, who are that subset of kids that like really need the specialty care the most, whereas other kids might need just regular follow-up with primary care or general mental health. So kind of, I'm going to go through kind of just like the details of like what it looks like, and then I'll share a little bit of some of our data that we've got from Utah. So who it's intended for are children ages 5 to 18 or their caregivers presenting in their primary care setting. And we're also doing this at children's advocacy centers for kids that are presenting for a forensic interview. I think probably most of you are aware of what the role of a children's advocacy center is, but if there's suspected maltreatment, that's where kids and families can go. It's kind of like a one-stop shop for a forensic interview, a medical exam, and then getting connections to resources, including mental health. For here at Intermountain, on the primary care side, what we're doing is that for every kid that is coming for a well child visit, either in a pediatric or a family medicine clinic, they're getting this trauma screener. So well child visits, mental health related visits, and then we do actually have some of our pediatricians are actually giving it for kids that are coming in for more of like a sports physical too. And then kind of like when and how the kids and family are doing it is that it was developed to be like a waiting room screening tool. So depending on the age of the child, it'll either be the parent or the caregiver filling it out, or it'll be the kid filling it out themselves. So we've kind of aligned it to be consistent with other screening tools that they use at well child checks. So for kids that are 11 and older, they'll fill out the screening tool on their own. And then if it's a younger kid, 6 to 10, maybe even 5, you'll have the caregiver fill it out. And then we've got it available in a wide range of languages. And then it's available on paper, electronic. So a lot of and if anybody actually has a child going to Intermountain, maybe you have seen this, but a lot of them are actually doing it on paper. We've got a couple people that have built it into like iPads and things like that, but it's intended of like, yep, this gets kind of filled out in the waiting room, and then the medical provider or medical assistant is going over the results with them. And then unlike a lot of other screening tools out there, what we've also kind of built in is then also like decision support. So we don't want to ask about trauma unless we're going to do something with the information. We've got the resources that we can offer the family. And so the 4 kind of key steps that it helps a provider make decisions about is kind of based off the information. So the first one is addressing just trauma safety concerns. So if the kid ends up disclosing something that wasn't known before, and that's reportable to CPS, that's kind of the first step is that, like, again, kids can't like heal from trauma unless they're safe. We've also got a question on there about suicidality, and I'll talk a little bit more in depth about that later. But that kind of also, there's a lot of overlap between kids that have post-traumatic stress symptoms and suicidality. And so this is also giving you information too of like kind of the level of risk that kid is and if they need a little bit more in that area. And then based off of the symptoms that the kid is reporting, then the provider is able to make a decision about just providing general psychoeducation to the family, but then also kind of figuring out like, well, kind of where are their symptoms and like what would be the next step. And then we've also kind of taught providers to teach actually like a brief in-office skill, something like belly breathing or mindfulness that the kid and family can take away that day and start using maybe while they're waiting to get into mental health care. So those are kind of the 4 key decisions. And let me move that. So this is kind of like a zoomed in version of what the screening tool looks like. The first 2 questions are just open-ended questions about trauma exposure. So we're asking about whether or not something has happened recently or something has happened in the past. And again, we're trying to kind of hone in on it was something violent or very scary or something where someone was hurt or could have been hurt. That being said, we get all sorts of responses on this in primary care that sometimes aren't exactly kind of in the way that we're thinking about trauma. So something more like, my mom made me go on a really scary ride at Lagoon. That's kind of not what we're talking about, all the way to kids who are disclosing things like child maltreatment, like sexual abuse and physical abuse and witnessing domestic violence. So those are the first 2 questions. If the kid says yes to either of them, or the parent or caregiver says yes, then they go on to the symptoms. Otherwise, the screening tool kind of just stops there. And then the second half of the screening tool is more of how it's impacted them. And so this is based on a validated tool called the UCLA Brief. And what we did is that we got some permission to make some additions and also kind of add in some quick ways that pediatric providers that, sometimes only have 15 or 20 minutes with the family so that they can score it up really quickly and make those decisions. And so what the kid or family is doing is that they're actually just asked about kind of how often they're having these behaviors or feelings or thoughts kind of in the past month. And so they're just kind of saying 0 to 4. And there's this little calendar to kind of help them tease out how often that might be happening. And it's kind of ordered in some of the PTSD symptoms that I talked about earlier. So the first 2 are about sleep difficulties and nightmares. The next cluster more about like the kids that are kind of like they're having a lot of arousal or they're on edge. So they're having those intrusive thoughts about what happened, might be on the lookout for danger. And then the last cluster of symptoms are the kids that aren't really wanting to like kind of talk about what happened, or they're getting dysregulated by being reminded about what happening. And then things that kind of look like depression. So I have thoughts like I'll never be able to trust other people. I feel alone when I'm not there. And then the very last question is actually borrowed from a different tool, and it's the patient health questionnaire. And this one's asking about whether or not the child or adolescent has had any like suicidal ideation in the past 2 weeks. And for kids that are saying several days or more, we have an additional tool called the Columbia Suicide Severity Risk Scale. And then that can give the provider an idea of kind of the level of risk. And help determine if like it's more passive suicidal ideation or if it's a kid that would benefit from more supports like a safety plan, or maybe even needs to get admitted to something like the ED. So that's kind of where the steps map onto. So again, the first 2 questions are going to give us an idea too of this kid is like physically safe and we need a report. And then the provider's making those decisions about kind of what's the next step for the kid based off of the symptoms. So for kids that are having like a lot of 3s and 4s, they kind of end up being in our severe range. And those are the kids that maybe actually would benefit maybe from coming to specialty care, like Safe and Healthy Families. The kids are kind of having more of like 1s and 2s on that screening tool. They usually end up being in the moderate range. Those might be kids kind of depending on the community. Maybe they can go to like a general mental health provider, or maybe they're already like connected to services. And then kids that are kind of like 10 and below, a lot of 0s and 1s. Maybe even if something big has happened, maybe they've already gotten some ports, maybe they're showing some resiliency. But it might be that it's kind of like what we call kind of like watching it in pediatric primary care. And so making sure that that primary care provider is kind of following up with them maybe more quickly than like their next well child check. The brief in office intervention. So again, most kids, even if they're in that mild range, they still might benefit, and that parent might benefit from just kind of some psychoeducation about trauma. Because again, kids don't come with instruction manuals, let alone when something terrible happens. And so even just giving some psychoeducation to the parent and the family can be really helpful. So these are some handouts too that I can put in the chat later too that kind of just go over like what is child trauma, like what are some of the behaviors that you might see. The middle one is a favorite, I will say, in our system. It's called the 3 R's of what you can do as a caregiver after something upsetting happens to your kid. And then the primary care provider, it looks like a prescription pad. So if they taught them belly breathing, they can actually kind of circle which one that they want them to practice at home. And then we've kind of put together a lot of handouts too that just kind of have multiple resources depending if the kid is having sleep difficulties or the avoidance symptoms. But really what these are intended to do is like, oh yeah, the kid is having a lot of sleep problems. Let's give them something to try that's going to help kind of giving them some symptom reduction in that area right away while they're maybe waiting to get into to mental health. And the neat thing about this too is that it actually kind of aligns with a lot of evidence-based treatments and kind of the beginning stages of trauma-focused EBT. So these are the components that are part of trauma-focused cognitive behavioral therapy. And basically, if the provider is kind of going through our care process model, they're kind of doing like psychoeducation, giving them some ways to kind of cope with trauma reminders up front. And then that way that kid and family already has a jump start then if they ended up doing TFCBT in our clinic without having to wait to be seen. We also kind of recommend just follow up because sometimes depending on the type of event that happened to the child and when it happened, you might either be seeing those symptoms emerged already, or they might not be there, or you might have a really avoidant kid who didn't really want to talk about what happened. So for both our primary care clinics that are doing this and children's advocacy centers, we're recommending both like a short-term and a longer-term follow-up. And some of that is because a lot of this is actually, it's happening through, actually having a conversation with the family about how the kid is doing and, making it open to talk about it, but also to make sure too of like, when you do follow up are things getting better? If you gave them a referral to Safe and Healthy Families, did they get in? So it kind of makes sure that you're also kind of following up to ensure that the family and the kids getting the care that they need. So that's kind of like an overview of kind of what the model is and how we're doing it. And so this next part that I'm going to end with is just kind of like, kind of what we've kind of found by doing this, both at Intermountain and across the US. This is kind of a quick and dirty map of kind of where we're at. So I'm going to talk mostly about our data here in Utah. But you can see we've been doing this with children's advocacy centers across the US. We've got a big primary care presence, and then we've also been adapting this for behavioral health, which is really great. And this is just our quarter data from just this past quarter from like over the summer, I believe. So we've got even like larger numbers. And a lot of lessons learned too, I think, about implementation just in different states. Again, if you're a person who likes to read, we do have some published studies about our primary care data. So leave those on there and I can get them to you later if you're interested. But I'm going to just kind of like end with, kind of how this is kind of unfolded. So again, we developed it in 2016. And then as part of that first round of funding, we started implementing in 2018 and did a pilot with a couple of the primary care sites that are here part of Intermountain. So you can kind of see those in the blue. And then I think another key kind of point for us is that we had a pediatrician, Neil Davis. He's been a big champion of kind of trauma-informed care and is leader within Intermountain Children's Health. And so in 2021, they were actually able to put a financial incentive for doing trauma screening. And that's why we have so much data. So basically, every time a kid would come in, especially an adolescent, then the provider would actually be being reimbursed for doing trauma screening. And so this was like a big win because pediatric primary care providers, they get reimbursed for a lot of other screening tools, but never for trauma. So we've had a lot more consistent implementation, I would say, since like 2021. I think another thing too that's probably a little bit relevant to your group starting last year, a couple of the pediatric primary care clinics are also doing a collaborative care pilot. And so they've got behavioral health case managers that are embedded in these settings. And so they've also been kind of big champions too of like, they're also kind of, the next step for kids that are doing the screening. And so this is kind of what it looks like. So on top of the trauma screener to get the reimbursement for kids that are 11 and older, they're also filling out a depression screener, the PHQ, and then an anxiety screener called the GAD-7. And so they're doing all three of these things in the waiting room. And then for the kids that are endorsing suicidality, like I mentioned, this is the Columbia. And so for those kids that are spending several days or more, the provider is also going through this risk assessment. And kind of what this does is that it kind of lets them know kind of like, are they kind of in the low, moderate, or high risk range? And then it also kind of indicates what you should do with that child. So if they are a kid that are in the low risk range, so these are kids that are maybe having passive suicidal ideation, they don't necessarily have intent or a plan. It's kind of providing a lot of like psychoeducation, maybe even doing some safety planning. Kids that are in the moderate range, more of a safety plan. And then kids that are in that high risk range where again, they've got intent, maybe recent behavior, then we're doing something more immediate. And then how this has come together is that kind of monitor how this was doing. We have a dashboard that we're able to look at weekly and kind of see like how many kids are being screened for what types of visits, and the types of symptoms that they're having. And then we're working on a more formal data poll too, so that we can publish this data, but also kind of look at more of the demographic information of the kids that are being screened. So that's kind of where this is coming from. So I'm going to kind of share some like big highlights. So we've got more data now, but at least this is data that we pulled from August 2022 to September 2023. In that time period, in both our primary care and our family medicine clinic, we had nearly like 20,000 kids that received this screening tool, which was amazing for me as a psychologist. Usually our samples are really teeny. And then most of our clinics are bought onto this. So like 100% of our primary care clinics are doing this. And then family medicine kind of just started coming on like last summer. So we're closer to about like half of those clinics are doing it. And then kind of what we found, so I'm going to go through it kind of based off of like the different pieces of our screening tool. So the first one is just like, well, how willing are kids and families, and how often are they saying that something has happened? And basically what we found is like 15% of the kids and families that are screened are endorsing either trauma that happened in the past, or recently. So this is about like 1 in every 7 triple screens. And that's helpful too, because again, primary care providers, they don't have a lot of time, right? So this isn't something that they're probably doing like at every visit, but probably maybe like once a day or at least like weekly, depending on how many kids and families they're seeing. And then kind of what their symptoms look like. So again, if you kind of look at this pie chart, over almost like 60% of our kids are in the low risk range, which again, primary care isn't necessarily like a high risk sample. Like if you look at our data in children's advocacy centers. So most of our kids are actually showing maybe some resiliency, or maybe they've already gotten some support. But what we're really concerned about, again, too, of the whole purpose of screening, what did I do? Skipped over one, is more of like, oh yeah, kind of these kids in that red range. So 21% of our kids end up scoring in that high risk range on the symptoms. So again, those are a lot of the kids with 3s and 4s. So they're kind of having a symptom pretty much every day. And 23% are in that moderate range. So those are the kids where if you're kind of thinking about like getting further assessment for trauma or even treatment, these are the kids that we really want to like focus on. And then if we kind of look at like the overlap for, again, of like the overlap with depression and anxiety, this was another question that we got from a lot of our primary care providers is like, well, could you actually just do step screening? Meaning like, could we just only do the trauma screener if the kid says, yep, I've had some depression symptoms or anxiety symptoms? And we said, you know what, we don't really know, but we can look at that with our dashboard data. And if anybody else has to present to primary care, one thing that they don't like to hear is that they've missed kids. And that's kind of what we found, is that they're actually like missing kids. So this table, if I kind of walk you through it, basically what it's saying is that for a lot of our kids that are having moderate or high traumatic stress symptoms, so again, if you kind of think of our screening tool, these are a lot of kids with like 3s and 4s. They actually aren't saying that they've got a ton of depression symptoms. So half of them actually have low depression symptoms. So if you weren't asking about trauma, you would totally miss these kids. And we kind of see like a similar pattern for anxiety, where again, it's like about like you would miss about 1/5 of those kids. So again, they have a lot of trauma symptoms, but not really are showing anxiety or depression symptoms. And for this, it's actually really important because that collaborative care pilot that we've been doing, the way that they get enrolled in that program is if at least that they have like a 10 on one of the symptom screeners. So these would be like traumatized kids that want to be getting enrolled in that program and have a chance to get some like short-term healthcare or even connected to some longer-term care. So that was a really important data point for us. Similarly too, just kind of speaking to what I shared earlier, there's just so much overlap. So even if we look at the kids that again, have high trauma symptoms, but also have high depression or high anxiety symptoms, you just see too much overlap. So half of the kids with high trauma symptoms, they also have high depression scores. Same thing too, it's a little bit lower for anxiety, but there's so much overlap that again, unless you're kind of asking about it and kind of learning about how it impacted the family, at least for in primary care where you've got physicians that can prescribe medication, they might actually kind of go down the wrong care pathway. And so if you remember what I kind of said about, oh yeah, it's trauma-focused treatments that help, you might be prescribing a kid then anxiety or depression medication, and then they come back to that provider a couple months later and it's not working and everybody's kind of frustrated. So this is really helpful to know that even if there's overlap, we still want to be asking about trauma, because if we're not resolving the trauma, we're also not going to be able to resolve the depression and the anxiety. And then the last point is just kind of talking a little bit more about that overlap that we see. It's really common for kids and families, especially after something has just happened, of experiencing suicidality. And so what this table is showing is actually kind of like that overlap. So these are the kids in our sample, only 60, but 60 out of that 20,000 that ended up being in that high risk range on the Columbia. So these are kids that had either recent suicidal behavior or had a pretty like concrete plan and intent to carry out a suicide attempt. And what we see is like 60% of those kids had a trauma history, and nearly half of them are having high trauma symptoms. So really just kind of honing in on the point too, that if you're going to have a trauma-informed response, usually you're also doing suicide prevention. So those are kind of like some big takeaways. Hopefully I've kind of skimmed the surface a little bit about why trauma screening, at least in primary care and children's advocacy centers, are important. Just kind of even like seeing that, like, yeah, kids and families, unless we ask about it, we might not know as providers, but also too that it really kind of opens up a conversation to talk about kind of what a kid and family has been through and what they've experienced, and also kind of instilling hope that like, oh yeah, we've got a lot of things that can help kids get better after trauma. Otherwise, I would not be doing this job. So here's a little bit of our contact information. I also put, I think a lot of you are nurses too. So we actually developed with the American Academy of Pediatrics a PediaLink course. And so it actually, you can get CE credits and learn how to do the care process model more in depth than what I did today. So we've got that available. And then we also do a lot of virtual trainings on this too. And then we're launching a web course that'll be a little bit more specific for children's advocacy centers in the spring. So I talked really fast and I have a cold. So I hope you guys have some questions or some thoughts, and happy to kind of go more in depth on some things or go back to stuff that I missed. But yeah. And I always go over more. I thought I was going to talk for 30 minutes. So Dina, I talked more than I thought.
Shannon, I have a question for you. I'm a nurse practitioner and I do not have trouble identifying kids with trauma because they're generally referred to me for that reason.
For that reason, yeah.
That part is easy for me. The thing that I'm looking for some guidance is I occasionally am able to locate some trauma-informed, get them into some appropriate care, which, by the way, is a huge problem. It's not very often. But I do have kids that are doing it. And parents get discouraged because they feel like they don't see improvement, like things aren't getting better. And then they come back to me and say, there's more to it. There's more to it. But clearly to me, it feels like it's the trauma. Can you just give me like an idea of when should we see improvements? And if we don't see improvements, what should I do differently?
Yeah, and I think it really depends on kind of like the age of the kid, how extensive their trauma history is, like what the behaviors are. Just to even give you like an idea, even for some of the kids that I'm seeing right now, like I have some really like more of like the kids in the preschool range, and maybe it's just kind of like a one-time trauma happened, and we're doing parent-child interaction therapy. And so like if I'm not seeing like improvement after a couple of sessions with that, I'm like, either this isn't the right fit or like I'm kind of missing something. Because like younger kids, I will say overall, they tend to get better a little bit more quickly, especially if you've got like the right intervention. Versus right now, I've got like a 17-year-old and he's got a pretty complex trauma history where, it was like ongoing neglect and various types of abuse from the time he was like an itty bitty guy until he was adopted at 8. And I didn't start seeing him until he was 16. It took us pretty much like a year to do TFCBT, and I don't think we saw a lot of like consistent symptom improvement until probably like a couple of months in. And part of it too is like if you kind of think about trauma symptoms, and I think this can also be really helpful for parents to hear when they're not kind of like seeing that like initial improvement, is that a lot of PTSD and trauma symptoms are about avoidance, right? Like it's gonna and trusting other caregivers. So like a lot of these kids that we see, they have every reason in the world not to even trust someone like me. So sometimes too, it takes a little bit longer to kind of get I think some momentum of just like, oh yeah, the kid kind of bought in of like, oh, this is someone that's going to be helpful and this is something helpful to me. So those are like two examples. And again, it might be a little bit more nuanced. And then I think sometimes too, I've had some families like prior to coming to see me that they thought they were doing something that was like a trauma focused treatment. And then kind of after hearing more a little bit about it, it probably wasn't. And that's not to say that that therapist or that provider wasn't doing good therapy, but there is like some specialties and some nuances for processing trauma too that not every mental health clinician gets in their training. So
I agree. And I think that might be part of it. At what age is it, or is it always appropriate to have parent-child therapy? And does Medicaid cover for that? Like, because to me, I feel like that's a component that is missing from some of my kids that aren't making progress, is that there needs to be the parent involved. Can you just tell me about what that looks like from an insurance standpoint?
Yeah. So, and I will say too, yeah, because I never want to throw other providers, right? And again, I'm always hearing it secondhand from a family, right? So I don't, it's hard to know. But to me, it's always a red flag that like if there hasn't been some kind of parent or caregiver involvement, and to me, that doesn't matter the age. But especially for kids that are under, I would say 10, a lot of times, like a big chunk of the work is actually working with that caregiver or that parent. So, and again, there's some models out there too, where there's like some nuances with like how you can like bill for sessions and things. Like even for us, there's a really effective treatment called Alternatives for Families Cognitive Behavioral Therapy. And that's actually to like work with the caregiver that maybe was physically abusive towards the child, and like reunification is the goal. But even within our system too, it can be hard to bill for that because a lot of the sessions are actually focused on the caregiver and not the kid. Parent-child interaction therapy is a little bit different because you've got both the caregiver and the kid the whole time, pretty much. Even TFCBT with that 17-year-old, maybe not every session I'm like checking in with a parent, but probably at least once a month, I'm like spending at least 30 minutes with that caregiver.
Thank you so much. I appreciate it.
Yeah. Yeah. That's a whole nother talk going through like trauma-focused EBTs, but yeah, but I think just kind of doing this work in Utah too, right? The resources are so different too, depending on like where you are in the state or even like what part of the valley you're in. So yeah, really good questions.
Shannon, that was going to be one of my questions was, you talk about if you're going to screen, but not be able to do something about it. I was going to say like what resources really are available for folks. I mean, we live in a very frontier rural state. So if you are, somewhere, maybe that's not the Wasatch Front, what sorts of resources are available to, help providers who may be concerned about, something like this if you are, rural or frontier area of the state?
Yeah, I mean, I think we're doing a little bit better with that too. And I don't know if many of you probably remember, if you're familiar with Safe and Healthy Families, Brian Thord is a very much like beloved psychologist, and he was the director here for many years until he retired. And so he's actually still doing a lot of active trauma focused CBT training across our state. And so even I think this was over the summer, like I think we even found somebody that Brian had trained is it Pierce, Utah? So like not to say like it can be really hard, but TFCBT does actually have like a website where you can kind of see like where there are like certified providers that are there. And I will say too, I think we have a lot of providers that we end up training where they don't. I'm in that boat too. I'm like, when I did all my TFCBT training, I was in training and very poor. So I'm like, I'm not gonna give all these people my money to get like certified. So there are people that are really good at this too that might not be on the website. So another thing too, I will say is that you can always call our social work line too, because we have kind of a running list too of like resources that are in our community. I think another good resource is actually Children's Advocacy Center. So All of our, I think other than maybe there's like two of them in our state that are not doing the care process model with us. And a lot of it has been kind of building up their mental health resources. So I think they're another good resource too, to like know what are like the local resources too. Because that's kind of part of doing the care process model is like, where can these kids go next? I'm also really excited for like our frontier kind of area. I'm blanking on her name, but she's in Washington County, and they're actually building up their children's advocacy center, like centers, like mental health services. So they have like a brand new building. They actually put in like parent-child interaction therapy rooms. So I think like too, there's a little bit of hope there. I don't know if this is like well known yet either too, but Intermountain is actually like opening up a children's hospital in Las Vegas, and so I think that's also gonna like help build up some of our services kind of in like the southern part of the state too. So it is challenging, but it's like not impossible. And I think too, even coming back from North Carolina, we had a lot of extensive trauma focused training in that state too. And there's still pockets where it's just really hard. And I think telehealth too. We've also got here at Safe and Healthy Families, we've got some providers that are able to provide services for kids that are on like Idaho and Wyoming Medicaid too. So I think we'll kind of see some like access improvement too as we're kind of like coming out of like active pandemic years. People are kind of learning about like how telehealth is effective and not effective too. So at least like bridging kind of like neighboring states, or even kids that are in kind of like maybe they need to come here for a more in-depth assessment, but then we can move to telehealth. Yeah.
Yeah, I just know that a lot of times with, Medicaid carve out here in the state with our behavioral health, and not always a lot of providers to serve all of our Medicaid recipients in these areas. Just the capacity for some of these providers at that, those behavioral health sites to be able to, handle everyone. So good to see this is evolving and training.
It's evolving. I think too, it's like, I know a couple of us, including myself too, we're like on a couple of like subcommittees and committees that are part of the state. And I'm sure a lot of you too just kind of saw like the big thing the state put out that basically says like, oh yeah, our mental health services for kids are really not great here. And it's like, well, a lot of people on this call could have told you that too. So I think there is some momentum, but like with everything to it, it's slow, a lot slower than I think any of us would like it to be. But yeah, I think between like local children's advocacy centers that have local lists, but also like, yeah, Safe and Healthy Families, I can put that in the chat or get it to Athena too. They're always happy. Mary is wonderful. She's always happy to be like, oh yeah, we've got, this person in this county that we know about. Yeah, other questions or thoughts? Yeah, I thought about, we don't have a lot of data from that collaborative care program, but I was like, oh yeah, I love working with our behavioral health care managers, and that's been a really helpful program. And we're finding that it's actually really helpful for getting kids some short-term support and then getting them into longer-term care. So if I come back, maybe I'll have more data about that. And we started doing kind of some more in-depth screening in our inpatient units too. And so we're getting some data on that. So we're trying to at least spread trauma screening too across kind of like Intermountain behavioral health service lines too. But again, a little bit slower than anybody would like it to be.
Sorry, I have a cold too, so I'm sorry if you can't hear me really well.
Yeah, that's okay.
So I'm a medical home coordinator, me and Alyssa, and we will get like calls from parents, like they're just like concerned about abuse and stuff like that. And so I was just wondering, what can we like normally tell them what to expect if we refer over to like Safe and Healthy Families?
Yeah. So yeah, if they get a referral to Safe and Healthy Families, kind of what it looks like for our families is that they'll usually first talk to like an intake coordinator, and that's a little bit of a longer phone call, like maybe 20 or 30 minutes, depending on how much they have to share. And that's just pretty much getting like basic information about the family, kind of what their initial like concerns are, like behaviorally and emotionally. Kind of some logistical things too, of like, where are they? What are their like preferences for days and times? Would their kid benefit more from like a female therapist if it was like sexual abuse, for example? So it's kind of like the first stop, and then they'll get put on our wait list. And I will say, compared to a lot of other outpatient clinics, probably because we're a specialty, ours aren't really that long. Like most of our families, like this time of year, are probably on our wait list for about like 4 to 6 weeks. Summer is a really slow time for us. So if you got somebody in the summer, that's usually like we could probably get them within like 2 weeks. Beginning of the school year, after the holidays, that's when our wait list kind of gets long again. So they might be on our wait list for a little bit. There might be some in-between things that have to happen. Like we might talk to if they have a CPS worker or a guardian ad litem, like those are sometimes some of the people that will make phone calls to before they're seen. And then once they get picked up by a therapist, they'll do an initial appointment, and that's kind of like getting to know the family, what their concerns are. The second appointment is typically meeting with one of our psychologists and doing testing. And that's all to like kind of inform like the interventions that we offer are going to be a good fit, and then helping them and the therapist develop a collaborative treatment plan together. And then it's actually doing whatever that treatment is. And then some of our families and kids will benefit from doing like a medication consultation with our psychiatrist, but not every family. And a lot of times I'll say, I'm just speaking to some of the data that we have. A lot of times Brooks is trying to get people off of medication rather than put them on it. So yeah, so it's kind of an overview, but kind of starts at that initial phone call.
Okay, awesome. Thank you so much.
Yeah.
I'm gonna let questions keep coming in, but I just want to just throw out a few reminders. I think some people have to hop for meetings right at 10, but our next meeting is December 18th, and our topic that month is going to be all around Medicaid. We have somebody from the Office of Long-Term Supports and then also the Office of Eligibility coming to talk specifically about services for children and youth with special health care needs and waiver supports and that kind of thing. So it should be a really good meeting. And then just a reminder I'll launch the evaluation here if you'll fill it out quick before you hop off. And then we'll continue to take some questions here for Shannon before we close out.
And I was going to say, Athena, I can send you a copy of the slides and like some of the resources too that I mentioned if you want to like disseminate it then after.
That'd be great. We always do kind of a meeting summary mail out after, and I'll be sure and include, we have the meeting recording that we send, and then also if you have slides, I'd love to attach those as well. So
Yeah, I'll give you the slides, and then it sounds like too, it'd be helpful for people to know just I've got like a handout too, just about like making a referral to safe and healthy families, and some of those resources too. So I'll put that in there.
that would be great. Any final questions? All right. Well, thank you everyone so much for joining us today. I hope you all have a wonderful Thanksgiving break, and we'll plan to see you all again in December.
Thanks, Athena. Thank you, Shannon.
Yeah, thank you.
Appreciate it.